Hello, everyone. Welcome to our October case conference. I'm going to go into the first case. So here's the patient history. The reason for referral was a breast cancer patient completed treatment and had a BRCA2 mutation. So this was someone that came to our clinic already with BRCA2 mutation identified. She'd had breast cancer diagnosed at age 46, which was ER positive, PR negative, HER2 equivocal, treated with subtotal mastectomy, chemo, and radiation, and genetic testing through her oncologist in Kentucky through Myriad showed this result. So BRCA2 C9699_9702 del. She had a risk-reducing salpingo-oophorectomy in May of 2021 and is currently receiving high-risk breast screening. So you see here her family or her personal and family history. Personal history, she had the breast cancer. But again, when we're looking beyond this, there wasn't many other hereditary breast and ovarian cancer related cancers in the family. So this was the genetic test result, again, that I've already highlighted. Now, here is an article that I'd pulled up with evidence for pathogenicity. So we have here the second listing here, which again says mutation co-occurrence indeterminate, does not, so there are some elements of this variant that don't support pathogenicity. Now, here's the thing, mother also got tested. She's a 72-year-old female, no personal history of cancer, and she self-referred for testing after she accompanied her daughter to the visit with me. She had tried to get testing through her PCP, but was told Medicare wouldn't cover it, and it would be $12,000. The family history, again, you can see here, leukemia in some of her sisters, later onset colon cancer in her mom. So again, she has this variant. Her sisters are in Germany, so again, wasn't super feasible in terms of figuring out how they could get tested. But again, we gave them the tools we were aware of. Again, this is going through evidence for pathogenicity. And again, I think this is one of those variants that may be associated in the biallelic state with Fanconi anemia. So again, there was some verbiage in here. I'm not going to go through this in a great amount of detail, but bottom line supporting this potentially being a hypomorphic variant. So again, I reached out to some of the labs. Bottom line was this may be a hypomorphic variant, so a reduced penetrance variant. RNA, from what I gathered from my discussions with a couple of the labs, will not help. There are 28 entries in ClinVar classified as likely pathogenic. I just pulled the ClinVar entry. And what I also found interesting here is that when you actually look below, there are labs that report this as a VUS. So I was a little surprised that it didn't say conflicting interpretation. But again, I think this gets into penetrance versus pathogenicity. With that, I'm going to open it up for questions. I also wanted to acknowledge that my friend and colleague, Dr. Alvaro Montero, was the one who was supposed to be giving our session today with the hurricane that hit yesterday in Florida. I don't think Alvaro has power, so I'm going to get him rescheduled for 2025. He'd given me a heads up already that he may not be able to make it. But again, our thoughts are with all of our friends and colleagues and family in Florida. But I just wanted to acknowledge that again, I was really thrilled to have Alvaro present because he does such a phenomenal job and he's been with ICARE from the beginning. But we will get him rescheduled. So I'll be the one giving the presentation, but I just wanted to open it up for any questions anyone might have, and then I'll go into my presentation, which again, I've been working with Dr. Montero as well as Dr. Couch and others on this topic, so I'll kind of provide my insight. So going into BRCA1 and BRCA2, very big picture wise, we know, like when we're talking about hereditary breast cancer genes, there have been two large efforts that were reported on back in 2021. What we call the Bridges study, which is a study of over 100,000 women from 25 countries, and then the Carrier study, which is a group of 64,000 women that were US based. That's the one that's led by Dr. Fergus Couch, Kate Nathanson, and others. So what was found in these studies were specific genes that we were able to confirm, hey, these are associated with higher risk for breast cancer. Now, when we're talking about high-risk guidelines, again, I like to point this out. These were released back in 2007 by the American Cancer Society. And really, this 20 to 25% threshold was released almost 2 decades ago. And what they said at the time was have a lifetime risk of breast cancer of about 20 to 25% or greater. So again, I do think it is time to really think about, well, what was this based on? And again, subsequent studies have shown that 5-year risks are more accurate than lifetime risks, especially for younger women. So again, just highlighting that age distribution when we're thinking about risk really does matter, and what the risk is over the next 5 to 10 years versus lifetime, which is what we often only have or what we are really using when we're thinking about what guidelines are telling us. Now, there are many risk factors that we also know that go into breast cancer risk, including the things that are modifiable as well as unmodifiable. So taking all that into account, there's a program that's been developed based on the Boadicea backbone called CanRisk that was developed by Dr. Antonis Antonio, who will be our speaker during our next case conference in November. Now, what this CanRisk program takes into account is a lot of our hormonal and other risk factor information, as well as the gene mutation. And with that information, we can then generate a risk. But again, keeping in mind that the risk that's generated is a specific number. So again, as stated by a famous statistician from the UK, all models are wrong, but some are useful. So I think of this as a useful guide when I am generating these risk assessments for patients. So again, as part of the CanRisk model, we can include information on polygenic risk scores. But again, what we know, and really all I'm trying to say with this slide is that most of our data pertaining to genomic studies have been done in whites, who represent about 16% of the world population. And this matters because predictions are less accurate in non-white populations. I think there are focus strategies to fix this, but that is still an issue. And then when we're thinking of polygenic risk scores, again, important to think about spread of risk. So if we have mutations in a specific gene and we overlay polygenic risk scores, we can actually spread out the risk to either further raise the risk or lower the risk. And again, it doesn't matter as much for the BRCA1 and BRCA2 genes, but specifically with mutations that are penetrant, so we're not talking about the hypomorphs. However, it does matter for genes like PALB2, where we can kind of toggle between high penetrance versus moderate penetrance, and then especially for CHEK2 and ATM, where we can, again, toggle between lower risk, lower increased risk versus moderate risk. And then all this to say, ascertainment certainly matters as well. When we have a clinic-based sample, we tend to have higher risks that are seen versus population-based samples, where you have a group of unselected individuals where the risks tend to be lower. So ascertainment certainly does matter. Now, when we're thinking about variant classification, our usual way of thinking about this is we have a benign or a negative, a pathogenic, a positive, or a VUS result. So usually 3 results. But what we're working towards nowadays, in my mind, is almost thinking of it as, you know, a negative, a positive VUS, but adding in this intermediate positive. So again, as we're learning more about these pathogenic variants, important to think about pathogenicity versus penetrance, and some of these intermediate risk variants are important to take into consideration. And this is a framework that has been considered through national organizations like ACMG that have put forth some additional guidance. Now, when we're thinking about BRCA hypomorphs, it really isn't a new concept. This R1699Q variant back in 2012 was reported to be of a lower risk. You can see here the line with the triangles. And then subsequently, with a reanalysis, this finding definitely held true with what you see in the blue line. So as many of you may have noticed, this is actually included in the most current version, or the current version of the NCCN guidelines, where we have now added this specific variant as an example. And I think there will be more, where it's about a 24% risk, and care should be individualized based on personal and family history, because with a 24% risk, we think of it more in the moderate penetrance range, which again has implications to patient care. And when we're thinking about BRCA2 hypomorphs, again, there have been functional studies looking at multiple modalities, but what I wanted to point out here is it's not just positive versus negative. There are ones with a mild effect, moderate effect. So it's almost this continuum of risk that exists, rather than saying, okay, well, something is positive versus negative, to make it not as simple for us. And again, these are more functional studies that have kind of showed, you know, yeah, we have neutral, we have deleterious, and then we have this intermediate group. And again, based on various different modalities that have been investigated, such as, you know, the lab cell survival, variant function, you see that there is this group that is not as clear cut, which may impart some risk, but not as much as what we typically think of with BRCA mutations. And this is work that has been done over many years by Dr. Fergus Couch. And again, we have him scheduled to present as our ICARE expert in February, but just more of a highlight, there are variants based on much of the work he's done where they're in the intermediate range. They're not clearly benign, they're not clearly pathogenic, based on multiple different ways he's looked at it. And then when we're thinking about BRCA mutations, even PRS does have the potential to spread out the risks. The risks do differ somewhat between the 5' middle and 3' end. This is work that was published within the last few years by Barnes et al. And then with addition of family history of breast cancer, again, you see that the risk is also spread out. So both for BRCA1 as well as for BRCA2. So all that to say, I do think that things are getting more refined as we learn more and do additional studies. And then BRCA1 and 2 missense versus truncating. Again, in clinic right now, we really don't differentiate between these two types of mutations. And I'm certainly not saying that we should, but again, there is some data that's emerged that suggests that some of these risks may be different. So again, more to come on that. We had presented we started working together, myself, Alvaro Montero, Fergus Couch, and then our colleagues at Ambry, led by Marcy Richardson, as well as Aaron Munt and team at Myriad. And what we did was we looked at some of these potentially hypomorphic variants across these two labs. We have a table here that I tend to refer to a lot. We have ones that were concordant across both labs, and then ones that were observed in one lab versus the other. But again, this is a paper that is currently under review. And again, the work is continuing. We have been awarded a grant, I guess it was last year, so it's no longer newly awarded, but Alvaro is at the helm, but both doctors Fergus Couch and myself are involved, as well as our laboratory-based colleagues who have been really fantastic to work with. Now, I'm talking about BRCA, but just to point out, this is not just a BRCA related issue. As many of you have also seen with CHEK2, there are some lower penetrance or reduced risk variants in CHEK2 that may not warrant the same level of care as what we typically consider a pathogenic CHEK2, like the 11, those variants in the same range of risk as the 1100 del C. So again, CHEK2 is one of them. ATM, we know of a higher penetrant variant, the C7271 T to G. There could be others as well. So again, the paradigm of relying on the gene to tell us the penetrance may be something that gets more complicated over time. And, you know, many of these items we have tried to highlight in some of our ACMG worldwide work groups that I have the list of the tremendous colleagues that I work with on these efforts. We've put forth a paper on PALB2 a few years ago. CHEK2 came out, I think it was last year, and ATM should be released imminently. We have the proof, so hopefully within the next few weeks. And then the other efforts under development, we're doing one on RAD51C and D, as well as BRIP1, and then a points to consider document, where, again, I think it's going to be increasingly important thinking about risks on a continuum. So ultimately, our goal is personal risk. We're never going to get it 100% right, but I think we're going to start doing better than what we can do right now. So kind of thinking about the gene and then overlaid with it, the mutation type, the polygenic risk score, as well as other factors that will give us a better estimate, hopefully, compared to what we typically are able to do now. With that, I think it's becoming evident that risk refinement is increasingly complex. And I do think here that communication strategies will be critical, meaning the genetic counseling that is provided to patients that really needs to be tailored to what the risks are for that patient. So with that, I will stop and take any questions.